Good evening, everyone. Welcome. Thank you for joining us for this virtual UMiamiHealth Talk, Fertility and Men's Health, Myths, Facts, and Solutions. I'm health journalist Ileana Bravo. I'll be your moderator for this evening's webinar, which is presented by UHealth's Desai Sethi Urology Institute. The Institute's mission is to deliver excellence in clinical care, to improve patient care through cutting-edge research, and to empower the next generation of urologists. They've assembled the largest group of fellowship-trained subspecialty leaders in the region. Many of these experts have been recruited from first-class institutions, and they're sought after both nationally and globally. The clinicians cater to a patient's individual needs, and they follow the time-tested adage of treating them like family. So we'll invite you to learn more about the Desai Sethi Urology Institute by visiting umiamihealth.org/urology. Contact them to schedule a consultation by calling 305-243-6090. We're going to put that up again at the end. Plus, you're going to have the benefit of receiving a recording of this webinar in about a week or so time. So hang in with us tonight because our panel of experts are going to delve into some of the most prevalent topics surrounding male fertility and men's reproductive health. And those topics include how to get started on your fertility journey, conceiving after testosterone therapy, fatherhood after a vasectomy, and optimizing male reproductive health. So it's my pleasure to introduce our experts tonight. It's Dr. Puneet Mason and Dr. Thomas Masterson. Dr. Mason is an associate professor and director of reproductive urology. He's a fellowship-trained microsurgeon and offers intricate surgical procedures, including microsurgical testicular sperm extraction, vasectomy reversal, and varicocelectomy. He also performs no-scalpel vasectomies. Dr. Masterson is an assistant professor of clinical urology with experience in both standard operating optical microscopes and 3D video microscopes. His research interests include treatment of male infertility, fertility preservation, testosterone replacement, and male sexual dysfunction. Now, here's a great opportunity for all of you in the audience tonight. At the end of their presentations, you're going to have a Q&A session. Now, this is a chance for you to ask direct questions of our expert. Now, experts, take a look at the Q&A feature at the bottom of your Zoom screen. It's a little box that has a question through it. That's where you're going to enter your questions, and we will prepare them and present them for our speakers to respond to. So now it is their turn. Let's turn it over to our medical experts to kick off tonight's highly anticipated topic. Gentlemen, make sure that you are unmuted and ready to go with your presentations.
Thank you, Ileana. Thank you, everyone, for making time for this. And I also wanted to thank our marketing team at the Desai Sethi Urology Institute and my colleague, Dr. Masterson, for being part of this experience. So welcome. If you're not able to see my slides, please let us know and we can troubleshoot. But I do believe they're on there. So we wanted to talk about fertility and men's health, and this is to go over the myths, facts, and solutions about male reproductive health. So with male fertility, when we're evaluating couples, we find that male fertility affects up to 50% of couples that are having difficulty conceiving. And, interestingly enough, male factor infertility is often overlooked in this process. And the question is, why is that? Well, there seems to be a general societal perception, at least there used to be, that fertility was primarily a gynecological problem. So as a result, the burden of the care falls to the woman, even though we are indeed 50% of the equation. Now, with that, what we see is that 25% of men that are presenting with subfertile parameters are never evaluated in the process. And what's concerning is 1 to 6% of men that are presenting with subfertility could have an underlying serious medical condition that should be addressed. When the male partner that could be presenting with subfertility is not evaluated, studies have shown that leads to a lower quality of life for not only that male partner, but also for the couple in general. And that can also lead to an increased cost of fertility treatments for both of them as they are trying to family build. Now, the great news is perceptions can change. And, what we have seen, at least, in the last decade or so, is a lot more people are speaking about their own individual fertility struggles. Now, we have that in the media, A lot of celebrities are coming out about this and talking about, their own journeys and how there was a male factor component. But the real champions of this, I do want to say, are the people that are having sidebar conversations, going on their social media accounts, talking to their friends and families, and about their own struggles with fertility. So because of the not only increased celebrity and social media awareness, we are seeing more men learning about, there are more men taking an interest in fertility. Now, also, what we've seen from an insurance standpoint, there's has been a change with providing more male fertility benefits for couples that are interested in fertility. And that can include things like a workup, fertility testing, but also fertility procedures that are centered around the male to help that couple family build. And generationally, we also see there's more interest in having the male become more included in this process, which for all of us is wonderful, because I do think that we are noticing that perceptions are indeed changing, which is great news. So the proactive inclusion of the male partner is becoming more mainstream. Men are more interested, legitimately interested in the reproductive health and being active partners in the family building process. And we see that with our patients. I've noticed that, I've been, I'm 45 years old. I've been doing this for 12 years. And I've noticed a substantial increase in the number of men that have been coming in on their own to get tested. So we're seeing men coming in, very early in this process. Sometimes men are coming in just to learn about the reproductive potential, and I think that's wonderful. Now, we're also noticing that over the last few years, we have an improved access to care, and that can be with home testing and also the, advancement of telehealth services. So because of that, we're able to expand our clinical footprint and, and make the pie larger. Essentially giving people more opportunity to get tested and, gain some awareness about their fertility. So our philosophy at UMiamiHealth, for anyone that's interested in fertility, we offer collaborative integrated couples care. And what that means is that we understand that, even though Dr. Masterson and myself are reproductive urologists, when people are coming to us, we're taking care of the couple in general, and because of that, we have strong standing relationships with our counterparts that do female fertility, with OBGYNs, with primary care doctors, because we want to make this as inclusive for everyone as possible. So inclusive male care, when people are more involved in this, it also improves access to care and accelerates the pathway to parenthood. So, many times couples may say, oh, well, why do we have to get evaluated even if we're going to go straight to, fertility treatments such as insemination or in vitro fertilization? Well, we know that when men are getting evaluated, optimizing the male care improves outcomes. So even if you're thinking about going straight to insemination or in vitro fertilization, you still want your male, partner to get evaluated, because we want everything to work really well for you. For men, when they come and see us, we can, part of our role as reproductive urologists is to identify things that could be corrective, things that we can change that can lead to, better quality sperm or better fertility outcomes in general. But also part of that is identifying things that might be non-corrective. And if things are non-corrective, at least we can counsel patients about, their fertility journey and what might be the best pathway to family build. It's also really important that if anyone is presenting with subfertility, that they get checked out. Remember I said earlier that 20% of men, 25% of men are never even evaluated. So if anyone is presenting with subfertility, they should get evaluated, because we want to prevent long-term deterioration. Because anecdotally, we have seen patients, when they're not evaluated, some can even progress to even more severe male infertility, such as something called azoospermia, which means no sperm in the ejaculate. So what does your fertility journey look like? Well, when men get evaluated, this is sort of like our general blueprint for what that looks like. So there's the initial evaluation, which can be either in person with a physical exam or through telehealth. Eventually, we're going to do some diagnostic testing. And by diagnostic testing, it might involve blood work to look at one's hormones, for instance, semen analyses to look at, what their fertility potential is like at the moment. We also might include some genetic testing that might be relevant for some patients, or radiology, studies such as ultrasound, MRIs, and so forth. So that's the diagnostic section. After that, you're gonna have an appointment which will involve a treatment plan. And that's when we get everything back. And depending on if the initial visit was through telehealth or in person, the treatment plan will follow, which may also include a physical exam. And then based upon that, we can figure out what's going to be the next step. And for some people, that could be lifestyle changes, because a lot of what we do involves reproductive strategy, So, and we will get into more so the lifestyle component later on into this talk. Part of this might include medical management, and there might be medications we can put you on that can accelerate your pathway to family building, or improve one's fertility potential. Or the male patient may benefit from a procedure, because there are procedures that we offer, that can help one with regards to their fertility journey. But once again, a lot of this, and the reason this evaluation is so important, is because a lot of what goes on in the initial evaluation and the treatment plan is a discussion of one's reproductive strategy and also family building goals. So that's basically what the journey would look like. Now, based upon some of the patients that we do see, there is a lot of discussion about what can we do to further improve us, when it comes to family building. So one myth that we see a lot is that, is there any benefit to being on testosterone or improving one's testosterone while couples are trying to conceive? So many of us, say that that hypogonadism or low testosterone may be one of the fastest growing diagnoses that we see. Everyone's talking about it. There are commercials everywhere. There are, male rejuvenation clinics all over the place. And it's something that people are legitimately interested in learning about, for good reasons. There are health benefits to improving one's testosterone. And a lot of patients with fertility that could be presenting with infertility have hormonal issues. So that's why it's really important we talk about testosterone in people that are presenting with fertility issues. So low testosterone, which is also known as hypogonadism, exists at up to 20% of patients who are presenting with infertility. So 1 in every 5 men that's coming to us with infertility could have a testosterone issue. So that's why we definitely check that as part of our evaluation. And in the course of that, we may be able to correct, their low testosterone medications to boost one's own testosterone production. So that's really important. It's really important to take medications to improve one's ability to make their own testosterone. And there are examples of these medications. Some men may be on it recreationally, but these medications are, the common ones are clomiphene citrate, also known as Clomid, anastrozole, also known as Arimidex, and HCG, which stands for human choreographic gonadotropin. So these are all medications that we routinely give men that are presenting with low testosterone to improve their testicles' ability to make its own testosterone. So the way I want you to think about this is think of your testicles like a garden, and immature sperm or seeds and mature sperm or flowers, and the amount of testosterone you have in your testicles is like fertilizer for the soil. So if there's not enough fertilizer in the garden, there may be some benefit to seeing one of us, because we might be able to put you on medications that can get your testicles to make more of its own testosterone, ergo adding more fertilizer in the garden. Now, the one thing that I want people to take home from this is to be very cautious of being on any form of synthetic testosterone, also known as testosterone replacement therapy, because when someone's on synthetic testosterone, one of the side effects is that it can adversely affect sperm production. It kind of functions like a contraceptive. 65% of men that are on TRT will progress to the point of having no sperm in their ejaculate just after a few months. So that's why for anyone, before going on any form of testosterone replacement therapy, either to treat your low testosterone or for recreational purposes, it's really important to think about what are your family building goals. Because if you are trying to have a family, anytime soon, that would not be the right medication to take. And come see one of us. We will test you if you're curious, and we can talk about other pathways or other things that we can do to either get your body to start making its own testosterone naturally or through medications. All right. So on that note, I'm going to let Dr. Masterson take over.
Of course, unmute. Thank you very much, Dr. Mason. A theme that you've kind of heard over and over again is sort of like fertility plan. So when we see patients after vasectomy, right, they're coming in knowing that they've had a procedure, that they are not going to be able to conceive children without any sort of other intervention. So vasectomies are a very common surgical procedure, and they're used to prevent unwanted pregnancies. What a vasectomy is actually doing is it's blocking the transport of sperm out of the testicle. So really, in the absence of any other things going on, you're still producing sperm. It's still there, and you have options to father your own children in the future. Patients will come to us. Oh, sorry. Hit the next one. Yes. So some patients after a vasectomy may decide, that they want to have children of their own, as opposed to saying going down the route of adoption. So next slide. What exactly are those options? Well, there are two. The first is to actually reverse the vasectomy. The idea behind a vasectomy reversal is you're trying to restore the capacity to get pregnant naturally. The other option is to do a sperm extraction. And what that means is that we're not going to reverse the vasectomy. We know that you're planning to do a cycle of IVF or move on to IVF, and we're taking sperm from the testicle to actually then inseminate an egg. Now, the choice between these two options is incredibly individualized, and things that come into play are the couple's desire. What is it that they want to do? Are they only open to conceiving naturally? Are they open to doing IVF? What are the health issues with the female partner, the male partner? There are cost issues associated with both of these options, and religious and family pressures. So it's a very individualized discussion. On to the next. All right. Now, a big question we get from just your patient coming in, what can I do to improve the quality of my sperm? So these are just general recommendations on what somebody can do in the absence of any other problems. So the first would be weight loss. We know that obesity, hit the slide. Obesity impairs sperm production. What's interesting is that people with morbid obesity actually have a higher incidence of azoospermia, meaning zero sperm counts. So weight loss or trying to get an ideal body mass index can improve sperm quality. The next would be diet. Here, yeah, thank you. A diet high in antioxidants we know can improve sperm count and decrease things such as sperm DNA fragmentation. Sperm DNA fragmentation is something that can basically lower your sperm's capacity to fertilize an egg or for the embryo to progress. Trying to decrease your diet in things that are high calorie or processed foods, as those can also impact your sperm production. Next, smoking. There's almost no health benefit to smoking. We know that smoking decreases sperm count, decreases sperm motility. So if you smoke, quit. Next slide. Stress. Any kind of stress, work stress, relationship stress, financial stress. Stress negatively impacts everything basically on your body. Wonderful study that looked at medical students, male medical students before final exams. Their sperm counts dropped the week of exams. So we know that stress can have a huge impact. Next, sleep. We know that poor sleep patterns decrease your testosterone levels. As Dr. Mason said earlier, testosterone is like the fertilizer for your sperm. If your testosterone levels are dropping, your sperm count is going to drop along with it. Ideally, you should try to get more than 6 hours of uninterrupted sleep per night. And the last, and this is one that we sometimes see in the media, scrotal temperature. Try to avoid situations that are going to unnecessarily heat up your testicles. Avoid saunas, avoid hot tubs. What about boxers or briefs? There's really no consensus on this. So wear what's comfortable. And with that, I think we will move on to questions.
Okay, thank you both very much. A lot to take in there and some very interesting changes in patterns. I think what struck me is the fact that you said that now men are much more included as a proactive partner in fertility. So basically, it's not just the woman's problem anymore. The man is saying, I want to be an active participant. Has that surprised you? And have you seen these trends grow in, I don't know, 5 years, 10 years?
Yeah, I mean, I've definitely seen that. And I think part of that, like we talked about earlier.
I think we lost Dr. Mason, but or I
Yeah, he
think he
just
froze.
for a
But I'm
moment.
happy to also just like to piggyback off his answer. But yes, there's definitely been a push, or I would say out at least in social media, because of things like men's health clinics. I think there is just more awareness of male fertility as a problem.
Yeah.
So I definitely in the past 5 years have seen more men coming in just for fertility screening, right? They haven't even tried to get pregnant yet. Some of them don't even have a partner. Some are they know that they're engaged and going to get married and they're thinking about the next steps and they just want to come in to see, am I okay? Can I move forward with fertility planning? And I think in the past that pressure was put more on the female partner.
No doubt, no doubt. Dr. Mason, you're back. You're
Yeah,
unfrozen.
yeah, sorry. So one thing that I started to notice this change, I would say about like maybe like 6 to 7 years ago, when I saw a sperm test on someone's wedding registry, you know? And I thought I was like, wow, how brilliant, from that standpoint. But that's good. I would rather buy that than a plate, But in terms of like what we're seeing, I think that's kind of like the introduction when I saw people really having an interest about this. And I think we were talking earlier about these fertility benefits that people have with their employers. Those fertility benefits cover testing. So because of that, when people learned of this benefit, they're like, yeah, might as well use it and may as well get tested. So I
Mhm.
think, what we're also noticing is that people like over time, people are waiting later to have families. So, rather than try for a few years on their own when you're later, when you're older in life, you might want to get tested sooner just to see, could there be a correctable issue that we could help you with? And
Mhm.
so much of what I said is reproductive strategy. So even like if you're not trying to conceive right now, but you might be thinking in like a year or so, just come in and see us because then we can at least get you started, and whether it might be, kind of like the lifestyle stuff we talked about, prenatal vitamins for men, things to look out for. These are all really important.
Yeah. And I'm going to remind the audience that you have a Q&A box. It's a little box that has a question mark through it. Please feel free to enter your questions right now as we're chatting. We still have a good 40 minutes for this talk, and we'd love to hear from you and what's on your mind. So let's launch into the first question that we got and talk about another topic that's huge all over the television screen is erectile dysfunction. So does erectile dysfunction affect fertility?
I mean, I'm happy to field this one. So directly, sort of indirectly, right? So, erections are there to basically deliver sperm into the uterus during, coital intercourse. So, if you're not able to get an erection to have intercourse, then you're not going to be able to get pregnant. But erectile dysfunction doesn't necessarily affect sperm quality or those types of things, depending on what the underlying issue is with erections. So it's not a direct link, but certainly indirectly can be.
Okay, let me grab some of these that just came over because people are now entering them. Thank you. Let's see. My son is now 18 and was born with no vas deferens, discovered during inguinal hernia repair. Should he wait until he's ready to have children to address his options?
So I can answer the question, in terms of figuring out what's going on, when someone has, no sperm in the ejaculate, they could have a sperm production issue, or they could have a blockage, or sometimes people have both, right? So, in someone that had a vasectomy, presumably that person has fathered children in the past and now has a blockage, right? So their testicles are still making sperm. I think, with your son, there might be some benefit in him coming in, getting tested, because then we can figure out, does he just have a blockage or is there an underlying sperm production issue that could be corrected? Now, I do want to say one thing about all of this is that, the world is rapidly changing. Fertility treatments have rapidly changed. Who knows what we'll have in the future when your son may want to consider being a father that we don't have available today. And that could be testing, it could be surgeries that we have. I think there's a lot of opportunity there. I've seen this field advance so much in the last 20 years, and it's going to continue to grow. So I do think there's some benefit, but the same token, important to have this conversation with your son, see whenever both of you are ready to come in, because he may not want to for some time, and that's totally okay. But whenever you're ready, we're here for you.
Yeah, I think the fact that people are being proactive and saying we're not ready to have children yet, but why not check? The physiology, the anatomy of an individual person to know if I'm okay. All right, here's a question. For patients that present with a low sperm or motility, do you recommend supplements? And you talked about lifestyle and foods and things to avoid and all that. What do you recommend in terms of supplements that you have found either from research or otherwise that work?
Sure. So first and foremost, people with low sperm count, low motility, you do want to get evaluated. So it's very easy to say, take some supplements, see if they work, but you do want to make sure that there's nothing else going on. Things like varicoceles, blockages, hormonal disorders. But assuming everything's normal, I do recommend supplements to patients. The reality is the data for them is not that robust. But when you weigh the sort of risk benefits, meaning they're very low risk as far as health issues, side effects, and so forth, but they may have some improvement in motility, concentration, and then other sperm count parameters. So I do, just throwing out a name, we Conception XR. It has a lot of ingredients in it that have at least individually been tested. But again, I wouldn't call them the first line.
Okay. Okay, Dr. Mason, here's a question that came, I think specifically to you. You were addressing it. Is the TRT-induced azoospermia reversible?
Right. So when we start people on TRT, not everyone counsels them about the risk, of the fact that they may progress to azoospermia. So if somebody has normal semen parameters, 98% of the time, we are able to successfully reverse them with other medications to get their testicles to make more of its own sperm. So that's really important to understand, is that you would come in, get evaluated, we would see what your hormones look like, and then based upon that, we may transition you from TRT to one or two medications to get your testicles to make more of its own sperm, i.e. make it more of its own fertilizer. But there's also a critical hormone that your pituitary gland makes that goes to your testicles, telling your testicles to make sperm. And that's your follicle stimulating hormone. So we want to make sure that we wake up your pituitary gland, and then we also kind of like wake up your testicles, from that standpoint. We're able to do this with medications. It just takes time. So we always tell people that, let's say you're in TRT and thinking about having kids in the future, come and see us about like 6 months before you want to have kids, so we can at least begin the reversal process, and that might open up more options for you. And a lot of our patients are able to get pregnant naturally, just given the fact that we're able to proactively plan for it.
Okay. All right, here's one. Do doctors recommend any particular exercises for stronger reproductive system? That's an interesting
Yeah.
one.
So I'm glad, someone asked that question, because it talks a little bit about lifestyle. So, we always, say that whatever's good for your waistline is also good for fertility, and I think like I'm guilty of this too. I think, I've noticed that I'm like, eating a little bit more and moving a little bit less than I probably should be, right? And we know that when someone has a lot of body fat, it can interfere with their body's ability to make its own testosterone, but also fertility. So we do always recommend that people engage in regular exercise. Now, there are some studies that show that if people are like the super athletes, and what does that mean? Obviously, like, people want to know what that quantifies to. So let's say you're using like, a Peloton like 5 days a week. Could you be putting excess heat on your scrotum that could interfere with your semen parameters? So initially, I always tell people, I'm not going to change anything until you get checked out. So come get checked out. Let's see if there's a problem. And if there's a problem, we can kind of figure out a way that you can modify exercise to vary it up a little bit, so you're still enjoying cardio or whatever it is you're doing, but we're also making steps to make sure that we're improving your fertility along the way.
Isn't that always the case? Too much of a good thing can actually be bad,
Yeah.
right? Excess. Okay, here's a common theme with a 66-year-old man, a 69-year-old man saying, look, I'm still thinking I want to have kids. It could be for a number of reasons, a second marriage, or, whatever those decisions are. What testing needs to be done? Is it recommended to make sure they're okay?
Yeah, I'll field this one. So first and foremost, unlike women who have menopause, men will basically make sperm to the day they die, as long as they remain relatively healthy. There's nothing really different that you would do as far as workup and testing, but a theme that is sort of emerging now is advanced paternal age. We know that, women, as they get to advanced maternal age, getting pregnant is much more difficult because egg quality seems to get less as they age, and there tends to be a higher incidence of genetic abnormalities and autism and things like this in women. Well, that pattern seems to also somewhat follow with men, that about past age 40 there is a higher incidence of autism in their children. Now, I wouldn't say that this is not a rate that is so high that I would tell you to be discouraged, but it is just something to be aware of as you are thinking about that process. So the testing doesn't change, right? Still semen analysis, hormone evaluation, but advanced paternal age is something that should be in the back of people's head.
Yeah. We talk about women with, issues of freezing their eggs. So here's a super interesting question. A patient with low sperm parameters that don't improve with treatment, should they freeze their sperm in case IVF is needed down the road?
Yeah, I can address that. When someone comes in to get evaluated and we find that they have, very poor sperm, whether it be lower numbers, lower motility, and all of us who do male fertility have a different magic number that we're comfortable with. But, I do recommend that they at least consider banking sperm, because we are still trying to figure out what's going on. And could they, over the next months or years, progress to not having any sperm in their ejaculate, So until we figure out what the underlying cause is, that is a recommendation that many of us give patients that say, okay, I'm glad you came in. Let's figure this out. Let's also bank sperm, because at least we'll have that in our back pocket, to figure out as we figure out what's going on.
Here's a question that really pulls at the heartstrings. This is a gentleman who says, my wife and I went through our first round of IVF. We had 11 eggs and 4 embryos. Unfortunately, the embryos did not continue to grow, and we didn't have anything successful from this round. What can you do to prepare for the next round? Vitamins, lifestyle, medicine?
Yeah. Questions like this are very hard to answer over this format because there's so many other factors involved. But it definitely, it sucks. It sucks when you go through all of that, the financial, the emotional, the physical, and have a bad outcome. But if you haven't been fully worked up on both sides, at least that's a place to start. Maybe there's something correctable for the next cycle to try to improve the outcome.
Yeah, I think also, like, what's important in the course of all of this is, for one, thank you for volunteering that information. Like we were saying earlier, we work very closely with the physicians that do IVF, the reproductive endocrinologists. So we kind of want to get more information about what went on during the cycle, because we wonder, could there be an underlying sperm issue that could also lead to, potentially poor embryo development? So, a semen analysis is part of the testing, but it's not the only testing we do. We also want to look at the DNA integrity of the sperm. So a semen analysis is like a video of sperm. It tells us, are there sperm moving? What do they kind of look like? How many are there? But it's, and we make a lot of assumptions about that, but it's not telling us anything but the DNA integrity of the sperm. So we do offer that testing at the University of Miami also, to do more in-depth testing of the sperm to see what's going on. But that's an important part of, the treatment process for some patients, and particularly somebody in your situation. We want to get that type of information.
And here's a question that I have. I mean, the high cost of in vitro fertilization is still, here we are, so advanced with treatment and everything we know genetically and so forth. Does that continue to just be as high as it is because of the steps involved? Is insurance coverage ever considered Talk to us a little bit about that. I'm sure it's highly frustrating for people to say, well, I'd like to have it, but I can't afford it.
Yeah. With in vitro fertilization, obviously, plays a huge part of what couples may end up doing, right? And I think it's important that we're sensitive to that. Some insurance, some states have mandated coverage where IVF or fertility treatments are included, and some states don't. Florida does not have a state mandate. Now, that being said, some employers in Florida may offer fertility coverage. So I think it's important that you check with your benefits manager, to see, are there plans that could potentially help you offset the costs, for some of these fertility treatments. So that's number one. But, because we live in the real world and cost is an issue, for that reason, it might be worthwhile to get checked out earlier, because if that is the only outcome, because, Dr. Masterson and I are going to try to do whatever we can to help you, but part of that is identifying things that we cannot do, right? So if somebody has very low semen parameters and there's nothing that him or I can do to improve those numbers, and we tell you that, your best option is to move forward with in vitro fertilization, it's important for the couple to hear this information sooner than later. So if cost is an issue, you can financially plan for that. So that's why, we are sensitive to this stuff. We want to make sure that we're giving you, as providers, we're giving you all the information you need so you can make the best decision for you and your family.
A registrant asked about having abnormal parameters on a home test and what should he do?
Yeah, the home tests I think are, first of all, great because again, it's expanding access to patients to at least get a screening. Now, I read the question and it sounded like there was about a 2-day delay between when he sent it and whatnot, and that's definitely going to affect motility specifically. So I would say if you have an abnormal result, it's worth doing some tests local, right, in a lab that's going to test it kind of on site within 1 hour. So, I would say I would just retest it before accepting it as a true result.
Mm-hmm. Now, talk about someone who is very progressive in their thinking. Look at this question. First of all, I thought of this too. How long does banked sperm last and what does it cost? And secondly, do you ever recommend that young men bank their sperm and then get a vasectomy so as to avoid unintended pregnancy? Now, that's someone with a very open mind.
Yeah, so I mean, I can start with answering that question, and then I think Dr. Master is going to want to chime in too. So, the majority of people that bank sperm are people that might undergo some type of treatment that would prevent them from making sperm in the future. So we see a lot of patients that are diagnosed with cancer that are going to undergo chemotherapy. And, we always recommend people bank sperm in that situation, because some of these men may not be able to recover that. And chemotherapy is one example. There are other medications. I've seen men that that are thinking about going on testosterone replacement therapy and bank their sperm in case they may be in the 2% that don't recover, or people that have very low semen parameters that we don't know what's going on. We're like, just bank some sperm until we figure this out and we may never figure this out and you might progress to not having any sperm. So let's keep this card in your back pocket. So banked sperm can last for decades. We have people in their adolescence that have banked sperm that are able to have children much later in life. So that's definitely the case. If anyone is at risk for potentially losing their fertility or has a risk factor that they may stop making sperm, just come and get checked out so we can at least begin that conversation with you. There's tremendous variability in the cost of banking sperm. The University of Miami, it's $460, and then after that, you would pay a storage fee, annually to keep it. The sperm to be banked at the University of Miami gets stored off-site in a protected, reproductive storage facility that stores like sperm, eggs, embryos, and a lot of different places use that because it's just safer, So that's kind of like how that goes. There are also commercial sperm banks that allow you to bank sperm. I don't know of any of those prices because there can be some changes depending on where you are located in the country. If you can go there and produce versus using a mail-in kit, etc. But my advice is that if you're local and you're able to make your way down to us, let's just do it in facility because, as Dr. Masterson said earlier, we want to eliminate transport as a confounding factor, in the course of this process.
I'd
Sorry,
like
I
to
forgot
talk
the second
about
part of the question.
Well, I think you answered it. I think the other one that I wanted to go to is, since vasectomy seems to have become more prevalent now. In other words, men are more open to say, look, I'm a proactive part of this couple, and I'll do my part. The onus is not just on the woman, so I'll do a vasectomy. So Dr. Masterson, you talked about the no scalpel one. We have new techniques, because of course men freak out at the thought of it, but tell us exactly what happens and how and why it's reversible and so forth.
Sure. Yeah, so there are definitely multiple ways to do a vasectomy. The majority of them are done in the clinic under local sedation, or sorry, under local anesthesia. So you're awake, you basically walk in, 15 minutes later, you walk out and the procedure's done. But we also do them in the operating room if it seems like that's a more appropriate setting for patients. But it's relatively quick. It's a non-hormonal treatment. Complication rates are fairly low. And it is a good way to prevent unwanted pregnancies. Compare that to what would have to do for the female partner for like a tubal ligation, which is going to be done under anesthesia. It's a laparoscopic procedure, which means you're going into the abdomen, and there's potential with any abdominal surgery damaging, abdominal organs and causing problems. So it is a much less invasive procedure. Vasectomies are reversible. As we touched on before, insurance and costs are an issue. Vasectomy reversals are routinely not covered by insurance, so it is an out-of-pocket cost. Circling back to the question before about banking sperm before the vasectomy and so forth, this is what I really like about reproductive urology is, you get questions like this, right? There's no single right answer for every single patient. It really is individualized care. So for some patients, that may make a lot of sense, is if you want to take that control, bank the sperm, know what those costs are, but understand that banked sperm really can only be used for IVF or IUI, which is going to have also associated costs with it. So, I mean, if you think that you're potentially family planning, that you don't have the money for IVF, then maybe don't do that. But those are discussions you have with your patients so that you come up with a plan that just makes sense for you.
Mm-hmm. Dr. Mason, I think you wanted to answer this question, or you put this in.
Yeah.
How may testicular varicocele affect male fertility?
Right. So that's a great question. Just so everyone knows, varicoceles are large dilated veins in the scrotum, and in some people, they can be a risk factor for male fertility. Now, varicoceles are very common. 1 in every 5 guys have them. Not everybody with varicoceles is going to have issues with fertility. Both Dr. Masterson and myself have done tons of vasectomies on guys with super large varicoceles. But because it can be a risk factor, I think it's important that if you have a varicocele on exam, or you think you might have one, come in and get checked out. And part of that evaluation can include a semen analysis. And if that semen analysis is abnormal, but you're not trying to have kids, but you want to have kids in the future someday, it might be worthwhile to get the varicocele treated when you're younger, because it might take at least 3 to 6 months before there's an improvement in your parameters. So we're getting kind of like a risk factor out of the equation. Now there could be other things that can cause abnormal semen parameters besides that, and there's no guarantee that fixing a varicocele is going to necessarily improve your parameters, but it might be something to take out of the equation, so that's what can happen. And the question is, like, how might varicocele affect fertility? Well, a guy's testicles have to be 2 degrees centigrade cooler than the rest of the body to create an ideal environment for sperm to develop. So just as Dr. Masterson said earlier, avoid any hot tubs, saunas, jacuzzis, all that stuff. Varicoceles, like, if there's a lot of blood in the testicles, because of these large dilated veins and blood pools in those areas, it can also warm up the testicles. So that's the pathophysiology behind it. Now, there's some other things that varicoceles can do that could cause infertility, and those are a little bit more technical, involving chemicals. And I don't necessarily want to get into that for this talk. But if you are concerned about that, come and see us, and we can talk about that in more detail. But that's just how varicoceles can be a risk factor. And if you do have that, and you're thinking about having kids either now or the future, it might be worthwhile to do some fertility testing.
Okay. How about antidepressants? So many people are on antidepressants. Is there any research, any study, any knowledge on your part that would affect sperm motility?
Yeah, so I think this actually was out of Cornell where they looked at this. But SSRIs, long term can have an impact on sperm motility. Now, whether or not that is a big enough impact for, us to say, hey, you should stop your SSRI, again, I probably wouldn't do that, especially if it's causing you benefit. So with many medications that patients are on that may affect their sperm, you just have to weigh what is the possible, risk to the sperm count versus what is the benefit of this medication. Other classes of medications, sometimes we can make very easy switches, right? There are some blood pressure medications that may affect the sperm's action as to penetrating into the egg, right? You can talk to their primary care and say, can we take you off of this medication, swap it out for that? And usually that's easy. And potentially the same thing can happen for your antidepressants, but we're not going to make those changes ourselves.
Mm-hmm. Okay, how about the ED medications, right? The erectile dysfunction stuff that someone needs the vasodilator, the Cialis, those medications. Does that affect sperm at all?
That's safe from a fertility
Yeah.
standpoint to take. I mean, I think one thing that's a great question because it opens up some discussion about the fact that, infertility, we're concentrating so much on semen parameters, hormones, for couples can present with infertility due to sexual dysfunction, and we also see that there is a lot of something I call the situational erectile dysfunction, which means people have no difficulty, having erections, but as soon as it comes down to like the time schedule of baby making, people can present with, some difficulty, and that can lead to distress, not only for the male, but also for the couple. So, we do see people in that situation, and a lot of times, it's important that they obviously focus on things to decrease stress. A lot of knowledge is a power. So we do, talk to them about fertility, about reproductive strategy, but, we prescribe those medications, things like Viagra, Levitra, Cialis, for people in that situation, which they can have something in their medicine cabinet or on demand and use it as need to. There's also lower dosages of medications people can take on a daily basis, like almost like a vitamin. So it takes the pressure off a little bit. But don't be, I want to say is that if you have these concerns, come in and get checked out because we want to make sure there's no underlying hormonal issue. But also there are treatment options for you to help you and your partner conceive naturally once we see what's going on.
Okay. This registrant asked, does the frequency of sex affect fertility and in this case also sperm motility? Like too much actually is not good?
Yeah.
Interesting
Yeah.
question.
No, there's actually this is a very good question. So, a lot of patients will come in sort of asking like, what's that fertile window? How often should we be having sex? Uh, if you're using apps and calculators, some people are trying to get it down to the minute, and they like, we need to do this right now because my phone is telling me we need to. But realistically, every other day is probably a reasonable amount during that fertile time. The idea with this from the male side is you want to have enough time to sort of build up volume. The more frequently you ejaculate, the lower your semen volume will be, and you may not just be producing enough to basically get where it needs to be. On the flip side, if you wait too long, right, you might be missing that window. So for patients who have been trying the apps, the calculators, and they're getting stressed out by it, my general recommendation is, if day zero, basically the day that she stops ovulating, or sorry, stops her period, every other day sex for about 3 to 5 attempts. So in that kind of 10-day window.
Yeah, so everything really is sort of scientifically calculated physiologically in the male body from
Yeah,
this.
I mean, once again, like when people are on the time schedule, sometimes it can lead to, sexual dysfunction. So what I generally tell my patients is that if you don't want to think about it, because some people get so focused on the strips and this and that and the calendars and the apps, and there's an alarm that goes off in the phone in the middle of clinic with them. What I tell people is that if you don't want to think about this, like something that might take the pressure off is whenever you think you might be ovulating, engage in intercourse like every other day. You know what I mean? Because then you're not really like you're kind of doing it, but you're also not so focused on the timing because that way you will always ensure there's motile sperm in the fallopian tubes. It also gives you time as the male to rebuild your volume and your sperm concentration.
Yeah. So I think the question that we have here tonight we have a specialized clinic that you gentlemen run, fertility urology, if you will. How does someone get to you? They're at their private family physician or an internist or something who may not be so skilled in this? Is it just referral? Is it seeing some signs first that something's wrong and then go to you? I think it's important that people realize the
Yeah.
pathway to get to a place like yours.
I mean, I think out of just pure curiosity, if anyone in this chat is interested, they can call us tomorrow and make an appointment. Some insurances do require a referral from your primary care doctor. So that's something that you might need. We usually do that on the back end and tell you if you need that. Like our office staff, when you call to make an appointment, will tell you if a referral's needed or not. That way you have everything that you need. We offer telehealth and in-person appointments. Telehealth is a great way to get started if you live far away. But we do offer, a host of different things. And we can also do a semen analysis when you're coming in to see us, because the lab where we do semen analysis is the same location where we have clinic. So that's an option. We can kind of, do two things at once to save you an extra trip. So
Yeah,
whenever
and
you're making your appointment, just like let them know if you're interested in that. Or let us know when we're seeing you that if you're interested in that. If you are going to do a semen analysis the same day you're coming to see us in person, please have 2 to 5 days of no ejaculations prior to that test so we can add you on. If you wait less than 2 days, then the counts might be inaccurately low. If you wait more than 5 days, there's going to be way too much dead sperm in the sample that can also throw off the results. And the phone staff will tell you this, if you're interested in doing a semen analysis at the same time, because they'll give you instructions about all this in case you forget.
And I'm glad that our comms team put the screen up so that everyone can see. They even have a QR code that they can scan and so forth to get to you, gentlemen. Because I think in the past, it's always been like the woman is the one who takes the lead in the couple, right? We can't get pregnant. We can't get pregnant. Something must be wrong with me. So you go to your fertility specialist. The female goes to the fertility specialist. And then they go, oh, by the way, it could be my partner's sperm as well. So does it start with the woman being the point of the center point and then evolves to now let's check the guy out? I'm curious as to how this happens, or are men just taking the bull by the horns saying, I'm going to check myself separate from my wife or spouse or partner?
Yeah, we applaud all
Yeah,
men,
it's both.
taking ownership.
Yeah.
So go on, Dr. Masterson.
Oh no, I mean I was gonna say it's I see both, right? Many times the female partner's been evaluated and is now pushing their husband, their boyfriend, their spouse to go get checked out, and sometimes it's the male partner coming in on their own, but there's no right way to go about it. If you're interested, you give us a call and we'll check.
Yeah.
Yeah, I think, so as per like the actual guidelines that are out there, 85% of couples are going to get pregnant within 1 year of trying on their own, right? Now, there are some exceptions to that, so obviously people can try on their own, but, interestingly enough, that amount of time, and this is well known, that couples might try on their own before they even get evaluated, sometimes is like 3 to 4 years, so that's all opportunity lost, So, we recommend that couples come in at any point to get evaluated. The evaluation for the male is very simple. It's that, diagram that I put up, like, an evaluation, whether it be telehealth or in person, that can include a physical exam at some point, some diagnostic testing, your blood and your semen, but also like so much of it is education. So you don't necessarily have to wait that 1 year, but if you are at that 1 year point, please come in, you know what I mean? So we can get a better idea of what's going on and help guide you in this journey, which is going to be extremely exciting, but we just want to help you in this.
Yeah, no, I agree. I like that sort of proactive thinking that people can say, I'm in control here. So this has been fascinating conversation, and we only have a few minutes left. So if each of you would give us a take-home message, and where are we these days, today, the 21st century, in 2025, how far have we come that we are having an open conversation about male fertility and how they can take an active part in this?
Yeah. So sorry, Tom, did you start talking? I don't want to cut you off.
No, I think she kind of just summarized it really well. So I didn't have a whole lot to add. But no, I mean, we really are living in an era now where there's a lot more that we can do, especially on the male side of things. 20 years ago, many of the surgeries that we're doing, the technologies we have just didn't exist. So there really is just a lot more options out there that you just may not be aware of. And that's part of the benefit of, coming to see, either myself, Dr. Mason, or really anybody on our reproductive team.
You know, and we also understand there are some really good questions in the chat that we didn't get to address all of them today. Some of them might, you know, be better to have a one-on-one conversation with us. So if you're curious about fertility, or you're being challenged right now with fertility, or it's something that you're actually concerned about, please come in and get checked out. The stigma for fertility is really gone, or is really changing, and people are more interested in learning about the reproductive health. So, you know, to all men that are listening, I applaud you for being an active partner in this process. For all women that are listening, and if your male friends are not, or your male partners are, please make the appointment for them. Tell them to come in and see us, you know, because we also, and come with them if you want, you know what I mean? Be part of the conversation. The beauty of telehealth is that you can have multiple people on one session. Because this is the only way we can get to offering comprehensive care for all of you, you know. So especially if you want to learn about reproductive strategy, what things that you can do that we did not address during this call. You have individual questions that, you know, that were not addressed during this, you know, we welcome any future discussions about that.
Yeah, thank you. I think we covered a lot, and it was a fast hour. It sort of flew by. But again, we thank you, our two medical experts tonight, for the privilege of your time. Very generous with the information that you shared. I know the audience is very happy about that, and maybe has changed a few lives tonight. So the program has come to an end, unfortunately, but we'll put back on the screen the information so that you can get in touch with the clinic. It's umiamihealth.org/urology to get more information. And for appointments, there's your number, 305-243-6090. You can even refer to the fact that you saw this webinar with Dr. Masterson, with Dr. Mason, and that you are interested in learning more and proactively come into the clinic. So we ask the audience to please complete the survey. Tell us what you thought of the talk. And physicians, Dr. Masterson, Dr. Mason, good night to you. Thank you so much, all of you, for joining, and have a great night, and everyone stay healthy out there. Good night.